Okay, so today we'll be talking about our technique for percutaneous lumbar-pelvic fixation. We're going to start right now with just putting percutaneous L5 pedicle screws. And so the important thing when doing percutaneous screws is, first of all, to get a nice crisp view of the end plate where you could see the appropriate pedicle. Are you able to see the C-arm? Yes. And so here I marked earlier kind of with my pen for the lateral aspect of the L5 pedicle, which is where you would want the gem sheety to start. So
Yeah, let's go ahead.
yeah, so now if we could
Let's see
kind of
where we're
advance
at.
and
Yeah.
put it in. Could we have a shot, see where we're at? Okay, so you're a bit low.
So let's correct our view to get a good end plate view. So let's tilt a little bit towards the head. Okay, let's take a shot there. Actually, let's go back the other way.
A bit more. Shot. I'd say that looks pretty good. So you're a touch low.
Beautiful. Okay.
So that looks pretty good. Here's the mallet. And so generally you want to start at like the 2 or 3 o'clock position.
And what I like here is that the gem sheety is parallel to the end plate, so it anticipates the lateral x-rays where you'll be parallel to the end
Could
plate.
I just have a shot? And so yeah, you want to advance until you're just about at the medial edge of the pedicle, at which point we could get a lateral view. Could you come in for a lateral?
And so we could sort of already anticipate what the lateral is going to show. So we're aiming a little bit up towards the end plate, but it looks like it's going to be safe. But in general, you just want to sort of anticipate what your other view is going to look like based on one view. So let's just sort of see here. All right, and so we reached the medial pedicle, so we want to be just at the posterior body, vertebral body, or just anterior to it.
It's kind of hard for me to tell. Try and kiss maybe the KV.
Yeah. Maybe if we go, yeah.
There we go. That's.
Yeah, maybe if we lower the bed just a little, or lower yours. Okay. Let's go up with the bed.
Okay, try that. Okay.
Okay. So we're not quite at the body, but I think we're close. So let's just advance it to the posterior body, and we'll just make sure on the AP that we are not medial to the pedicle there.
Yeah, because on the AP we still had a little bit to go. Okay, let's get a shot.
So I threw the gauntlet down at you guys before. Percutaneous screws very frequently are looking short to me. Did you hear me? Okay, carry on. Sorry.
Okay, so that's right at the posterior body. So let's come up to the other view.
Yeah.
Let's go up to our last view that we had.
Yeah, and over here we just want to make sure that we're not past the medial aspect of the pedicle.
Okay.
Okay.
And so we're going to be safe there. So we're right at the medial pedicle and at the posterior body. So let's come back to the lateral. And then we're going to, you could go ahead and advance the gem sheety a centimeter. Yeah.
You may eventually want to extend the incision a bit, but yeah.
Two cranial. So that was sort of anticipated based on the appearance on the AP.
And so
I think it's going to be okay. So let's just keep
it'll
going.
be fine.
Yep.
You could just kind of direct it down a bit, try to
Yeah.
see if you could get any compensation.
Yeah. Okay, that's good. Yeah, so let's get the Jamshidi.
Shot. Okay. And now if we could get the wire. So you put in the wire and advance it a bit further than the Jamshidi. And so, yeah, generally speaking, exactly. I like taking the needle driver and just bringing it down to hub it with the Jamshidi, and that also stops you from going too deep. Perfect.
Measure based off of this? Or
No, it's usually with a pre-op plan this.
Yeah.
So does it feel like there's bone at the end of that? Like you're in bone? Like when you were, when you first put it down?
Yeah.
Okay, perfect.
Okay.
All right, so let's just take this out and we'll put in the screw. So we are, usually we would have templated the screw based on the CT scan, but we're gonna put a 6x45 here.
Yeah, and it's easy to back out the wire when you take the Jamshidi out. So either you or have someone hold it for you so it doesn't back up. Oh, there we go.
And so ideally we would want the screw aiming just a little bit distal. So what we're gonna do is just advance it to right when the screw threads start getting into the posterior body there, and then we'll aim a little bit distal. So X-ray there. Okay.
Let's see how to give you some room.
Shot there. Okay. Yep.
Then once you're in the body, so bring your hand down. You want to be in line with the wire. Sorry.
We're trying to
Other-
correct.
What? Oh, yeah, correct. Okay. never
Okay.
mind.
Yeah. Keep going.
the wires going out the front?
Yeah.
I'm tracking, so take it out, right?
Yeah.
Yeah. Okay.
Should be loose.
Okay. So we chose a length that was a little short, but that's gonna be fine. So let's do this, and we'll have you come around to this side, and we'll do the iliac bolt. All right, so we're going to come up to the teardrop view, and really, in terms of the
something I
pelvis,
can
what
point
we're trying to instrument is
Where
the
is,
column bone between the PSIS and
this
the AIIS. And if we think of what we need in order to put a safe screw is just a cylinder or bone. And in general, we could define a cylinder in space sort of by a view down the tube itself or two orthogonal views. And so what this teardrop view is, David, if you want to point out the stuff on the floor right
Yeah.
here. All right, so we'll take a shot here. And so let's pull back towards you. And then let's roll over the top as much. Oh, actually, that looks
Yeah.
pretty good.
And are you able to see me?
Yeah, yeah.
So over here you have the teardrop. And
so
this
we'll
is
zoom on
actually,
to
if you're
needles.
looking at the tube head on, kind of like a telescope, that's where you would want to see the screw inside this area. However, one of the issues with this view is that the boom of the C-arm is right in the trajectory of your screw and kind of gets in the way. So if you could, and so what happens is the screw would end up coming in like this, if you could move the camera to the cadaver. Okay, you can see that, and so it's hard to put a screw and have live verification when you're on fluoro.
All right, let's take an X-ray there, please. Okay, yeah, so that looks great. So let's just put a mark there. And so really the teardrop view is just a view for you only use it for the start point, and as a confirmatory view for safe screw placement at the end. And so now we'll have you roll back to an iliac oblique. We can come straight up. Yeah, and then let's take our knife. We're gonna make our incision. And the key here is to remember that our dissection needs to be heading outward to our start point. So, and you have a cob? Yeah. So just make it, don't worry about it. That's good. So just get it down to the fascia. And here, really, we need to delineate the fascia. Is there a bong? Just a smaller guy. This is fine, yeah. Okay. All right, so don't go through the fascia. Okay. Okay, so yeah, okay, so we're there through the fascia. So you want to make sure that you have your fascial incision just a centimeter medial to the palpated PSIS.
And again, with these, the key is you want to have the fascia to be able to repair at the end.
Okay, so let's get your Jamshidi, or sorry, the cannulated pedicle finder. All right, and then let's come straight up and straight to a straight AP. Yeah, that's going to be pretty shitty. And then let's go to an inlet view. Okay, and let's take a shot there. All right, and let's move towards the foot. X-ray there. All right, and push in just a little bit. X-ray. And so what we're looking on for the inlet there is whether we have a crisp anterior line. And so we can maybe go to the video looking at the fluoro.
Yeah.
Sorry, can we get the fluoro video, the fluoro screen up? Okay,
Yeah.
you're gonna have to take a step back. So there you can see that we don't have a crisp line. So we're gonna need to play with our tilt a little bit more. Okay, X-ray there. All right, so it's starting to become more crisp, another like 4
Exactly.
degrees. Okay, X-ray there. Okay.
And that's
Are we
pretty
at
good.
0 degrees in terms of the roll?
And what essentially you're looking at
Can't
is,
see that, David. So this is the position of the pelvis here in the patient. Now you're going to roll over the top so that we are tangential to this view here.
That's maxed out.
Okay, yeah, so that's right around where we were. And then and pull back towards you a little bit. Yeah, shot there. Okay. And okay, and then we could go just a centimeter towards the foot. And David, you want to point out the landmarks there?
yeah, yeah. And so if you could come to the view of the fluoro, the other camera.
Yeah,
Okay, perfect. So over here you have the outer table, here you have the inner table, here you have the SI joint. And so you're basically looking at the pelvis
medial
kind of
just
like
a little
that.
and
So the safe corridor would be to, come here crossing the SI joint and get in between the tables and stay in between.
yeah, and so here, so these are what we're aiming for. These are our field goals. So this line right here, and this line right here, and here's the hip. So let's take a shot there. Okay, so that looks promising. So let's get a mallet. Okay, X-ray there. All right, and then let's just see. We're gonna have to aim, but let's just see in terms of our cranial caudal trajectory we trace. We're gonna come back to that iliac oblique. Okay. Yeah, you got it here. Let's take a shot there. Okay, and lower your machine a fair amount. We need to drop a lot more. Keep going. Yeah. Okay, and stay. So on that view, you could see the AIIS right above the hip, that little bump there, and you can see that we're aiming well cranial a bit, so we're going to aim distal. Yeah, let's take a shot there. Yeah, so we'll keep going more in that direction. X-ray there. Okay, and I think that looks promising. All right, so let's mallet that down. Shot there.
Okay, yeah, so I would definitely want to keep that trajectory.
Yeah.
That looks pretty good. if we could go back to our other view right now, because we just want to make sure that we're not sliding down the SI joint and that we're headed in between the tables.
Yeah. And ideally, we'd have we'd use a pedicle finder that's pretty sharp. Perfect. And again, this view here, just to picture where it is, we're just getting the tangential view to this outer cortex here. X-ray. Okay, so we need to aim quite a bit more lateral.
Yeah.
Yep. So you need to pull back maybe a little bit, and you could just So that's it. Yeah.
And I want you to notice that as we're getting these views, the boom of the C-arm is not getting in the way.
Can you roll over the top a little bit?
A little more over the top.
Yeah.
We're max concentration.
Okay. Pull back towards you a little bit. Okay. X-ray. Okay. Yeah. So just exaggerate that to cross the SI joint. Yeah. Okay. So let's take a mallet. X-ray. Yeah. Keep going.
Keep going, yeah. So now he's crossing the SI joint, and now he's making it into.
Okay. So yeah.
Now he's crossing the inner table and is within the goalposts.
Let's come back to the other view, because once we cross the SI joint, really our trajectory is pretty set. So we'll confirm that our cranial caudal trajectory is good. All right. And all right, let's take a shot there. All right.
And that looks pretty good as well.
Yeah, so you could go ahead and lower, keep going. Yeah, so then we could advance that. Let's come and let's do the rest on the other view.
Yeah. And really the densest bone is right above the sciatic notch. So if you kind of just skirt on top of it, you're going to get extra good fixation.
At this point, do you still use the hammer? Or do you...
Yeah, mallet, yeah.
Yeah.
It's going to be an interference fit. You could try advancing it, but yeah, yep. Yeah, yep, keep going.
Keep going.
Okay, and let's turn it so that it's in line with this, so we can bounce off that lateral cortex. Yep. Keep going. Yep. Okay, you hear a change in pitch there. So let's get the wire now. So we'll take this. So we're using a cannulated pedicle finder, so we don't have to find the hole again.
Yeah. Do you want to get the iliac oblique so we could show how far you went?
Yeah.
So let's get that other view.
Does it feel like bone? Yeah. 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 So we're going to put that in. Yeah, we're going to put X-ray there, please. Yep.
And could you lower the machine? Yeah.
Okay.
You can see we're
All right.
pretty far.
And so let's send this in like another inch, and let's go to the other view. Sorry about going back and forth. So when we get close to the outer cortex, we'll use the wire to maximize our length. So we'll have it deflect off the lateral cortex. All right. Yeah. Okay. Let's keep sending this down.
Yeah. And if I had to guess, this is already longer than 100. We only have an 80 screw here today.
Yeah. You keep going. Keep going. Okay. And so we'll keep this wire and take this out. So you can see that's how far we can reach on this. So, and the longest screw that we have available today is an 80. So you'll see, so keep this picture in mind. Yeah, we're gonna tap here. So we should be able to get at least 100. And so the reason that we tap in these is it's pretty dense bone. So actually, this is one scenario where I'll tap line to line. There's a lot of insertional torque, and so have definitely when I have tried to under tap, have occasionally broken off tulips. And so really, we just want to tap across the SI joint. X-ray there. Okay. Yep. So. Yeah, you keep going. You have another 20 millimeters or so. And do you happen to have a T-handle for the screw? Okay, perfect. Okay, X-ray there. All right, that looks good. So we can, come on reverse.
And could we come to the other view and left to right it so that we could see how deep the screw goes compared to how deep we went?
You have a needle driver, please? Thank you. Okay, we'll put our screw in.
Okay, shot over there. Perfect. And so it's a bit lower than I would ideally like, but that's still a safe screw and will have very good fixation. Could you left to right that? Perfect. Okay, and now we could put the screw in. We could continue with this screw, with this view. Let's get a shot, see where we are. Okay.
And the key here is to get the tool up underneath the fascia, so that's why we clearly delineate the fascia at the very beginning of the case. All right. All right. It's a beautiful sound, All right, X-ray there, please. All right, and keep sending it down, and as he's sending it down, let's come to the other view. Okay, let's take a shot there. Okay, all right, so, yeah. And then, so what we'll do here is we'll sort of take a peek if we go to the overhead. So what we're looking at is just where the tulip is relative to the fascia, and that looks like it's right there, so we could probably go in another 2 or 3 turns.
Yeah, because again, the big thing, you want to be able to close the fascia above the tulip.
Yeah. Okay. Yeah, just a little bit more. Yeah. Okay. All right. I think that's good. All right. So let's pull our wire, and you can see here that this is an 80 screw, but we would have had enough real estate with this trajectory to at least get to a 110, probably. Sorry. No, you're fine. Nice. Okay. All right, and now our next step is to pass our rod. So let's disconnect this, and let's, I think, let's get a teardrop view just to verify the screw, to verify that it's safe.
And so the good thing is you're getting constant live feedback as to where you are. There are obviously other methods to do it. Each one has their pros and cons. A lot of people who like to navigate this, I think navigation is fabulous, but you get a trajectory of the screw.
So let's roll over the top a couple degrees.
A little more?
Yep. So pull back towards you. A little bit more. Okay. Let's get a shot there. Yeah. And so you can see that that screw is entirely within the teardrop there. So it's safe. Okay. And so we can, and so I guess, Jens, how are we doing on time? Okay.
We could probably come to a close soon.
Yeah. So I think the next step, so we could come out. The next step would be just to pass the rod and to secure it. And it's a pretty straightforward thing to do with two, with just 2 screws. And if we can sort of, yes. So we'll sort of hold this here. What makes it so much easier, especially with the slope of the sacrum, is to actually pass the rod from distal to proximal, because if you try to go the other way, you need to curve quite a bit to come up the slope. And so that's really the one pearl for this, is to pass the rod from from caudal cranially. But besides that, it's pretty straightforward. And so I think any of the folks watching this video will know how to pass the rod. So we'll sort
Yeah,
of
this
see.
is one question I had. So you talked about submerging the pelvic screw under, and the radiographs are very nice, by the way. I liked how you double teamed that. I've revised a fair bit of these lumbopelvic percutaneous fixations, and I've always found that the rods are epifascial, and these screws are always on top of the fascia. So there seems to be a fundamental problem trying to actually bury these screws behind the iliac crest. So why is that? What do you do differently? You talked about dissecting the fascia, but I'm still not sure that the crown of the screw and then the rod insertion doesn't actually just sponge this all down again.
Yeah, so I'm going to try, let me see the cob here. And so we directly visualize that. So if we can see there, let me. So there's the fascia. So I directly visualize that the fascia right here. Sorry, get my fingers out of the way.
This patient probably would not mind if you open up the skin incision a little bit more.
Oh yeah. All right, let's get a knife here.
Yeah, here you go.
I have an ongoing collection of percutaneous masterpieces. I just shared some with Dr. McGuire.
Here's this knife back, and so you can see here this tulip is clearly underneath the fascia, and that's something. And so that's not just by feel. Like we actually, so the way that I knew that was by putting when we have the smaller incision, putting it down here and flicking the fascia and just actually looking down there. So you need to do this with direct visualization. And the other issue that comes up, Jens, related to that point is when we have that rod in here. So we need to make sure that the rod is okay. Wait here. That the rod is not too distal relative to the tulip, because as the more distal you go, the more prominent it becomes.
Right.
And that's commonly the tulip may be underneath, but if you have you really need to be careful with your rod length, especially distally, because that's it can become problematic, especially in our thinner patients.
So now one more thing, when you do a triangle fixation, a true triangle fixation is putting an L5 or S1 screw and then a iliac screw, and you put an SI screw across. What do you do first, SI screw or the iliac screw?
Oh, so
The SI screw I would do first. It's easier for me with these views to navigate around the SI screw than it is to navigate the SI screw around the iliac screws.
Yeah, the iliac corridor, as David is saying, is just so huge. It's huge where you can fit multiple screws in that corridor. Frequently, the corridor of bone for the iliosacral screw, depending on the morphology, you may only have an 8 millimeter corridor for a 6 millimeter screw. And so you start off with a screw that has where you have the least wiggle room, which in most cases is the iliosacral screw.
Yeah, we actually published this technique in the NAS journal, and over there's a case example of someone who had like pelvic ring hardware and a bunch of screws through the corridor, and using these views, we were able to navigate it around all the hardware.
Yeah, and around the anterior expix sites as well.
Let's come to a close. We're all running out of gas. Thank you. Nicely done.
Thank you. Good job.
And come on, join us here for the final two cases, and then we'll close. These are the closure cases.